When we think about a heart attack, most of us picture someone who is older, unhealthy, or completely inactive. However, cardiovascular events can affect seemingly healthy individuals, including dedicated athletes. To understand how these events happen, it is essential to examine the anatomy and physiology of the human heart. The medical term for a heart attack is a myocardial infarction. Myo refers to muscle, cardio to the heart, and infarction means tissue death caused by a lack of blood supply. Essentially, a heart attack occurs when blood flow to a portion of the heart muscle is restricted or blocked, starving the tissue of oxygen and nutrients. Without prompt restoration, this muscle tissue eventually dies. This blockage typically originates in the coronary arteries. Early anatomists named them coronary because they resemble a crown encircling the heart. These vessels branch into smaller pathways, including the left anterior descending artery. Often nicknamed the widowmaker, this specific artery supplies a massive portion of the heart. If a significant blockage forms here, it can be fatal because it affects such a large area, unlike minor blockages in smaller branches. The most common underlying cause of these blockages is coronary artery disease, involving atherosclerosis. Atherosclerosis is the buildup of plaque within the artery walls, consisting of fatty cholesterol deposits, calcium, and other substances. While frequently forming in the coronary arteries, this process can affect any artery in the body, such as the carotid arteries leading to the brain, potentially causing a stroke. Over years, these plaques grow larger, gradually narrowing the vessel and reducing downstream blood flow. People often develop no symptoms until a coronary artery is occluded by roughly 70%. This silent progression can be unsettling because dangerous blockages occur without warning. Even at 70% occlusion, the blockage alone does not trigger a heart attack immediately. If the plaque is stable, a person might first experience chest pain only upon physical exertion, such as climbing stairs, which disappears with rest. This predictable pattern is known as stable angina. However, most heart attacks happen suddenly when a stable plaque unexpectedly ruptures. The body attempts to heal this rupture by forming a blood clot. Unfortunately, this protective response backfires because the clot forms rapidly and can completely seal off the artery. This abrupt interruption leads to classic symptoms, including intense chest pain, or pressure radiating to the arm, neck, or jaw, accompanied by shortness of breath, nausea, sweating, or lightheadedness. Symptoms can be much more subtle in women, sometimes manifesting merely as fatigue or mild indigestion. When a heart attack strikes, time is critical. While the myocardium is resilient, irreversible tissue damage can begin in as little as 20 to 40 minutes, with total blockage emergencies escalating rapidly within an hour. Immediate hospital intervention is vital. Treatments include clot-busting drugs or an angioplasty. During this procedure, a tiny catheter is threaded through an artery up to the heart, where a balloon is inflated to compress the plaque against the vessel wall, restoring normal blood flow. Frequently, a stent is deployed to keep the artery open permanently. Understanding what accelerates plaque development helps clarify why seemingly healthy individuals are vulnerable. The process largely hinges on the tunica intima, the delicate inner lining of the arteries. Anything that damages or irritates this lining promotes plaque formation. High blood pressure places constant mechanical stress on the tissue. Harmful chemicals from smoking cause chronic inflammation, and elevated blood glucose levels from unmanaged diabetes further erode the lining. When combined with genetic predispositions and elevated cholesterol, they create a recipe for severe vascular disease. Beyond traditional plaque-induced heart attacks, individuals can experience other forms of cardiac distress, such as atrial fibrillation, or A-fib. A-fib is the most common cardiac arrhythmia, involving an irregular heartbeat. The upper chambers of the heart, the atria, beat chaotically and out of sync with the lower ventricles, leading to a rapid heartbeat, shortness of breath, and lightheadedness. Because the atria flutter rather than fully contract, blood can stagnate and form clots within the chambers. A-fib can overwork the heart, sometimes triggering a type 2 myocardial infarction, a heart attack driven by severe stress and oxygen mismatch rather than direct plaque rupture. The human body also has built-in mechanisms to protect itself. Collateral circuits, networks of smaller arteries and capillaries, can supply blood to an area from alternative sources. When primary coronary arteries develop plaque, the heart can naturally grow new collateral vessels to compensate. Furthermore, consistent cardiovascular exercise powerfully stimulates the development of these new collateral pathways, making the heart far more resilient to cardiac events. Ultimately, maintaining optimal cardiovascular health requires proactive care regardless of fitness levels. This involves routine annual physical examinations to monitor blood pressure, blood glucose, and lipid panels. For individuals at higher risk, physicians may recommend advanced screening tools such as coronary artery calcium scans or CT angiograms to detect and quantify calcified plaque buildup. By combining regular cardiovascular exercise, a balanced diet, smoking cessation, and effective sleep and stress management, we can significantly reduce our risk of cardiovascular disease and support long-term heart health. Like and subscribe for more cognitive insights. Have a nice day.